after 6th of July. Good morning everyone. Good morning bachcho. Just let me know, am I audible and visible to all of you? Am I audible and visible? Shubham, let me know that please. Goyal, Parveen, good morning. Good morning. Just show me a thumbs up if I am audible and visible. Pranav, I'm good. Mahalakshmi, I'm good. Thank you, Dr. Shubham, for confirming that I am audible and visible. So let's not waste your time. And today's session is very, very important. This is basically going to cover all that you need to know on labor, right? Everything you need to know on pelvis, everything you need to know on labor. I'm going to quickly revise it for you. As I told you, कि ये sessions ना, they are basically for revision sessions. This is not an understanding concept wala session. This is a quick revision session which we are going to take. Labor में क्या क्या questions आते हैं, we are going to revise them, and all those potential questions which I feel can come, I'm going to revise them also, right? So we are going to begin with pelvis. A pelvis में what is important is inlet के diameters, and that too the AP diameters of the inlet. You should know what is the plane of least pelvic dimensions, plane of greatest pelvic dimension. You should know interischial diameter, you should know intertuberous diameter. These are 5 things which I want all of you to know in pelvis, so that you are prepared for any question which comes on pelvis. So let us quickly see what are the AP diameters of the inlet. Ab AP diameter of the inlet means कि आगे you are going to have pubic symphysis, anteriorly, posteriorly you are going to have sacral promontory. Now, if the AP diameter is measured from upper border of pubic symphysis to sacral promontory, right, this line, this is what is called as true conjugate, right? So, from where to where is true conjugate? True conjugate is from upper border of pubic symphysis to sacral promontory. I'll just write it slightly properly so that you understand what I have written. Right, and what is the value of true conjugate? 11 centimeters. Then we have the obstetrical conjugate. Obstetrical conjugate is from middle of pubic symphysis and up till the sacral promontory, right? So this is obstetrical conjugate. What is the value of obstetrical conjugate? It is 10.5. Shine beta, Neet PG students can see this, watch this session definitely, but you need to know slightly more than this, right? This इतना तो चाहिए ही चाहिए, मतलब there is no doubt कि इतना चाहिए कि नहीं चाहिए, इतना तो चाहिए ही. So this is 10.5 centimeters, right? And then we have the diagonal conjugate, which is from lower border of pubic symphysis going up till sacral promontory, which is 12 centimeters. Now quickly tell me, out of true conjugate, obstetrical conjugate and diagonal conjugate, सबसे smallest कौन सा है? Smallest is obstetrical conjugate. This means that if head of the fetus can pass through obstetrical conjugate, it can definitely pass through the other two also. So that means अगर कोई हमसे पूछे which is the obstetrically most important AP diameter of the inlet, so obstetrically the most important AP diameter of the inlet becomes obstetrical conjugate, and that is why नाम भी दिया obstetrical conjugate. Now there is something which is called as critical obstetrical conjugate, and all those who are the DBMCI students or Marrow students, quickly tell me, what do you mean by critical obstetrical conjugate? What is critical obstetrical conjugate? Dr. AM, very good. Critical obstetrical conjugate is that value of obstetrical conjugate below which normal vaginal delivery is not possible, and that value is 10 centimeters. अगर obstetrical conjugate 10 centimeters से less हो जाता है, if obstetrical conjugate becomes less than 10 centimeters, Dr. AM गलत बोला है. If obstetrical conjugate becomes less than 10 centimeters, then it is called as critical obstetrical conjugate, and then vaginal delivery is not possible and you have to do a cesarean section. Pelvis will be called as contracted pelvis, right? So critical obstetrical conjugate is that value of obstetrical conjugate. I don't know ये सब तुम लोग कैसे 8 centimeters answer कर रहे हो. The answer is 10 centimeters. 8 centimeters वाला आंसर अलग आंसर है. Don't get confused. Now, tell me which of the AP diameters of the inlet can be measured clinically. Which AP diameter can be measured clinically? जल्दी बताओ. Which AP diameter of the inlet can be measured clinically? जब हम क्लिनिकल एग्जामिनेशन करेंगे हमारी फिंगर कहां टच करेगी? लोअर बॉर्डर ऑफ प्यूबिक सिम्फाइसिस, राइट? सो दिस इज, that means which diameter can be measured clinically? Diagonal conjugate can be measured clinically, right? So clinically you can measure diagonal conjugate, right? Okay, so this means कि हम measure तो clinically diagonal conjugate कर सकते हैं, but हम contracted pelvis को define करते हैं in terms of obstetrical conjugate. So how am I going to know whether my patient's inlet or pelvis is contracted or not? I cannot measure obstetrical conjugate. For that, what I am going to do, I am going to subtract. So if diagonal conjugate is x centimeters, then obstetrical conjugate is x minus 1.5 centimeters, because normally diagonal conjugate is 12 centimeters and normally obstetrical conjugate is 10.5 centimeters. So जो भी value of diagonal conjugate is coming in my patient, I am going to subtract 1.5 from it to get the value of obstetrical conjugate, right? And if that value comes less than 10 centimeters, I'm going to call it as a contracted pelvis. You can say x minus 1.5 or 2, that's okay. ठीक? Now, उसके बाद I want all of you to draw a line which should be going from S to S3. अब ये line बनाओ. S to S3 से lower border of pubic symphysis. एक line बनाओ from S to S3 going up till the lower border of pubic symphysis. Now tell me, ये जो line बनाई, जो मैंने अभी pink color की ये line बनाई है, what is this line representing? What is this line representing? This line which I have drawn just now from S to S3 going up till the pubic symphysis, what is this line representing? जल्दी बताओ. I want your answers in the chat box. Excellent, Deepak. Awesome. Priyanshu, very good. This line is representing plane of greatest pelvic dimensions. Plane of greatest pelvic dimensions. So whenever a line is drawn from S to S3 vertebra going up till the lower border of pubic symphysis, that represents the plane of greatest pelvic dimensions, right? अब उसके बाद मुझे बताओ, what is this line? I am drawing a line from S4, S5. I am drawing a line from S4, S5 going up till the pubic symphysis. What is this line representing now? S4, S5 से I have drawn a line going up till the lower border of pubic symphysis. What is this line representing? And in सब पे questions आता है. What is this line representing? A line going from S4, S5 up till the pubic symphysis. Indrajit, awesome. This line is plane of least pelvic dimensions. ठीक है? So all of you remember कि if you are drawing a plane from S to S3 going up till the pubic symphysis, or if you are drawing a plane that is called as plane of greatest pelvic dimension, S4, S5 से going up till the pubic symphysis, that is the plane of least pelvic dimensions. A plane of least pelvic dimensions में posteriorly you have S4, S5, anteriorly you have pubic symphysis. Laterally, बीच में क्या आता है? Lateral में क्या आता है? Laterally आता है ischial spine. प्लेन ऑफ लीस्ट पेल्विक डायमेंशंस में लेटरली आता है ischial spine. So all of you close your eyes quickly. Posteriorly imagine करो S4 S5, आगे imagine करो pubic symphysis, sides में imagine करो ischial spine. That is plane of least pelvic dimensions, right? Now I want all of you, because this was a previous year NEET question and definitely this can be asked in your FMGE exam. I want all of you to imagine the plane of greatest pelvic dimensions. Plane of greatest pelvic dimensions क्या है? पीछे की तरफ S2 S3, आगे की तरफ pubic symphysis. अब ये जो प्लेन बनाया ना S2 S3 and pubic symphysis को, इसको बनाओ roof of a room. एंड फ्लोर ऑफ अ रूम बनाओ प्लेन ऑफ लीस्ट पेल्विक डायमेंशंस को. प्लेन ऑफ लीस्ट पेल्विक डायमेंशंस में पीछे क्या था? S4 S5. साइड्स में क्या है? ischial spine. एंटीरियरली क्या है? pubic symphysis. सो आई वांट यू टू इमेजिन अ रूम जिसके रूफ में है प्लेन ऑफ ग्रेटेस्ट पेल्विक डायमेंशन, जिसका फ्लोर इज प्लेन ऑफ लीस्ट पेल्विक डायमेंशंस, राइट? दिस इज योर ये जो एरिया जिसके रूफ में यू हैव प्लेन ऑफ ग्रेटेस्ट पेल्विक डायमेंशन एंड जिसके फ्लोर में यू हैव प्लेन ऑफ लीस्ट पेल्विक डायमेंशन, ये जो एरिया कलर हुआ, दिस इज योर मिड पेल्विस. कपकेक बेटा, आई एम टेकिंग सेशंस फॉर नीट PG FMG both of you are as much dear to me. IMGs FMGs both of you are dear to me, right? So these sessions are OBGY sessions. Take it as an OBGY session. It is not for NEET PG या FMGE. Knowledge तो सबके लिए same है ना? ये question has come in your exam. So this is your mid pelvis. Mid pelvis. So the area which lies between plane of greatest pelvic dimension and plane of least pelvic dimension is mid pelvis. अब सबसे इंपॉर्टेंट क्या होता है प्लेन ऑफ लीस्ट पेल्विक डायमेंशंस में कि इसकी लेटरल बाउंड्री इज ischial spine एंड इसको प्लेन ऑफ लीस्ट पेल्विक डायमेंशंस इसलिए कहते हैं बिकॉज द ट्रांसवर्स डायमीटर ऑफ दिस प्लेन, द ट्रांसवर्स डायमीटर ऑफ दिस प्लेन, दैट इज द डिस्टेंस बिटवीन टू ischial spines, distance between two ischial spines, which is also called as interischial diameter, is the smallest diameter in the entire pelvis. It is 10 centimeters, right? So why is plane of least pelvic dimensions called as plane of least pelvic dimensions? Because the transverse diameter at the plane of least pelvic dimensions is the smallest in the entire pelvis. The distance between the two ischial spines is 10 centimeters. यहां तक कि obstetrical conjugate was also 10.5. Yeah, this can also be called as the bispinous diameter, right? So this is 10 centimeters. And so interischial diameter, they ask you what is the overall most important diameter? Overall most important diameter in pelvis. Overall most important diameter in pelvis is interischial diameter. ठीक है? Now, last thing which I want all of you to remember is, let's draw a line from coccyx going up till pubic symphysis. ये line coccyx से pubic symphysis तक, और laterally imagine करो यहां पे है ischial tuberosity. So I am telling you that now I have drawn anatomical outlet. What is anatomical outlet? ये जो green line है, this is anatomical outlet. So I want, yes Indrajit, we have obturator foramen also there, but question नहीं आता अभी मैं, I am not explaining the concepts, I am just telling you questions कहाँ पे आते हैं. Right, now I want all of you to imagine posteriorly there is the coccyx, आगे क्या है? pubic symphysis. Laterally क्या है? ischial tuberosity. That is what is anatomical outlet. Practically all of us are sitting on our anatomical outlet. जहां पे पीछे we have the coccyx Anteriorly we have pubic symphysis, laterally we have ischial tuberosity, right? अब in anatomical outlet, देखो, in anatomical outlet, again the most important diameter which you have to remember is the transverse diameter. Transverse diameter of the anatomical outlet will be the distance between two ischial tuberosities, and that is why it is called as intertuberous diameter. Intertuberous diameter, right? Intertuberous diameter is 11 centimeters. Clear to all of you? So I want you to remember these diameters, all the three AP diameters of the inlet. I want you to remember transverse diameter of the plane of least pelvic dimension, transverse diameter of the anatomical outlet. I want you to remember the boundaries of the plane of least pelvic dimensions, plane of greatest pelvic dimension. I want you to remember what is mid pelvis, and I want you to remember anatomical outlet. Now, last time के NEET में they had colored this area of mid pelvis and they had asked that what is this area representing. Now I want all of you to do just one more exercise for me. And that exercise is कि again close your eyes and imagine the plane of least pelvic dimension. जितनी बार imagine करोगे ना उतनी बार याद होगा. So plane of least pelvic dimensions क्या था? Plane of least pelvic dimensions posteriorly क्या था? Posteriorly you had S4, S5. Anteriorly क्या था? Pubic symphysis. Laterally क्या था? Ischial spine. Right? Now make this the roof of a room. Right? Make this the roof of a room. Now, अब imagine करो anatomical outlet. Anatomical outlet क्या है? Anatomical outlet is posteriorly pubic symphysis. Posteriorly coccyx, anteriorly pubic symphysis, and laterally क्या है? Ischial tuberosities. Make it the floor of the room. So ऊपर है हमारे पास रूफ पे वी हैव प्लेन ऑफ लीस्ट पेल्विक डायमेंशंस. यहाँ पे देखो पर्पल कलर का प्लेन ऑफ लीस्ट पेल्विक डायमेंशन. फ्लोर में क्या है हमारे पास? एनाटॉमिकल आउटलेट. सो ये जो दोनों के बीच में एरिया अब हम कलर करने जा रहे हैं, दिस एरिया विच आई एम गोइंग टू कलर नाउ, दिस इज ऑब्स्टेट्रिकल आउटलेट. द एरिया बिटवीन plane of least pelvic dimension and anatomical outlet, this is your obstetrical outlet. ठीक है? I will, Janvi, all PDFs I'm going to provide. Don't worry about that. Blank PDFs are there on SSS group and on CTG group. Annotated PDFs are also there of the previous sessions. Today's session PDF will also be there, right? After the session is over. Abhi, today I will be taking your gynae session also. Gynae session ka PDF, the blank PDF is already uploaded on both these groups since yesterday. Ab samajh mein aa gaya pelvis, all of you? Okay. Then, another thing which they ask you, and this is your question, beta. This is an FMGE PYQ. Identify the type of pelvis. Identify the type of pelvis. A. Gynecoid, B. Android, C. Platyploid, D. Anthropoid. Identify this pelvis and tell me what type of pelvis is this? A, B, C or D? Prachi, I will take. I am not going to ditch the NEET PG students. Definitely I'll be taking sessions for you people. बताओ, गायनाकॉइड है कि ये एंड्रॉइड है कि प्लैटिपिलॉइड है या एंथ्रोपॉइड है? आई एम सो हैप्पी टू सी ऑल ऑफ यू आंसरिंग. Excellent. Excellent. This is gynecoid pelvis. Arjun, Tanvi, I'll tell you why this is a gynecoid pelvis. देखो, जब भी pelvis की शेप पे कमेंट करना है, you have to look at the shape of inlet. ठीक है? Now, in order to identify the shape of inlet, you should be knowing the boundaries of inlet. Right? So, I know all the DBMCI bachas and all the Marrow students are knowing this because this question I make you do in the class as well. Dekho, boundaries of inlet mein you have pubic symphysis, then you have pubic crest and pubic tubercle. Theek? Then you have this line over here. This line over here is called as the iliopectineal line. Then you have sacroiliac joint. Right? Then you have ala of sacral bone. Right? And then you have sacral promontory. And इसी तरीके से from the other side I am going to come back. Right? So अब बताओ shape क्या बनी? What is the shape which has been formed? What is the shape which has been formed? The shape which has been formed is a round kind of a shape, and round shape or slight transverse oval is the shape of gynecoid pelvis. The problem or the mistake which you people do is you call it as heart shape because क्या करोगे तुम यहाँ आओगे and then you will take it like this and go like this. But this is not the boundary of the inlet. Right? You don't have to go up till the coccyx for the boundary of the inlet. Coccyx पहुंच गए तो आप outlet पे पहुंच गए ना. So shape of the inlet को देखते हुए you have to decide, and for that you have to know the boundaries. So this is oval shaped or this is round shape, and that is why this is a gynecoid pelvis. I want all of you to look over here. So once you look at the shape of the inlet, if the shape of the inlet is round or oval, shape of inlet, if it is round or it is a transverse oval, then that is gynecoid pelvis. Gynecoid pelvis is the most common variety of pelvis. In gynecoid pelvis, the transverse diameter is more than AP diameter. Transverse diameter is more than AP diameter. Next important point about gynecoid pelvis is that this is the female type pelvis. This is female type pelvis. Right? Now coming to the next pelvis, and that is this pelvis where you look at the shape of the inlet. How is the shape of the inlet? The shape of the inlet is heart shaped. Shape of the inlet is heart shaped, and obviously heart shaped inlet किनकी pelvis में मिलेगी? Male की pelvis में. Male pelvis has heart shaped inlet. Another important point about android pelvis is here also beta, the transverse diameter is more than AP diameter. Transverse diameter is more than AP diameter. Next important point is this is the only pelvis with prominent ischial spines, and that is why it is not favorable for delivery. Next important point, this is the most common pelvis which is associated with occipito-posterior position, and this is the most common pelvis which is associated with deep transverse arrest. Right? These are the points which you have to remember about android pelvis. If you look at the walls, it's not suitable for delivery. Definitely it's not. If you look at the walls of the pelvis are converging. Right? The side walls are converging. That is this type of pelvis which is android pelvis. Then we come to anthropoid pelvis. Anthropoid pelvis is a pelvis जिसकी shape is AP oval. Antero-posterior oval. This is the only pelvis जिसमें AP diameter is more than transverse diameter, and that is why question is asked over here. This is the pelvis which is associated with. Now I want all of you to be very, very careful, beta. If they ask you most common pelvis associated with occipito-posterior, then your answer is android pelvis. But if they ask you a question, most common pelvis which is associated with persistent occipito-posterior, or they ask you a question which pelvis is associated with direct occipito-posterior, whenever occipito-posterior के front में some kind of prefix is added, the answer changes from android to anthropoid. That is how you have to remember. Whether they ask you direct occipito-posterior or whether they ask you persistent occipito-posterior, your answer has to be anthropoid pelvis. Next, this is the pelvis which is associated with face to pubes delivery. Excellent. All of you were saying right, face to pubes delivery. Right, so these are the points which you have to remember about anthropoid pelvis. Then comes the least common variety of pelvis, which is platypilloid pelvis. In platypilloid pelvis, again the shape of the oval, the shape of the inlet, please remember it is a flat bowl-like shape. It's a flat bowl-like shape. Right, the other important point about platypilloid pelvis, over here transverse diameter is much more than AP diameter. And this is the pelvis which is most commonly associated with face presentation. Please don't confuse with face to pubes delivery and face presentation. Face to pubes delivery was common in anthropoid pelvis. Face presentation is common in platypilloid pelvis. So these are the important points which you had to remember about varieties of pelvis. The classification of pelvis is called as Cadwell-Molloy classification. Cadwell-Molloy classification, right? Other than that, I want you to remember two more types of pelvis. One is Negley's pelvis. What is a Negley's pelvis? A Negley's pelvis is where one ala of the sacral bone is absent. If one ala of the sacral bone is absent, that's a Negley's pelvis. And then we have a Robert's pelvis where both the ala of sacral bone are absent. Right, both these are varieties of contracted pelvis, and because they are varieties of contracted pelvis, management in them is cesarean section. So whenever it is Robert pelvis or Negley's pelvis, management has to be cesarean section. Now they have started asking you questions on cardinal movements of labor and the sequence of the cardinal movement of labor. Whether you are a Neet PG student or whether you are FMG student, they will give you 4 or 5 movements and they will ask you to arrange them in sequence. Now, if you are a Marrow subscriber or if you are a DBMCI student, I have shown you how vaginal delivery happens. What is the normal mechanism of labor? Quickly tell me what is the first thing what is going to happen? The first thing which is going to happen would be that the head of the fetus is going to enter into the pelvis. When the largest transverse diameter crosses the pelvic inlet, that is what is called as engagement. Engagement. Right? So first step is engagement. Dr. AM, first step is not extension. Beta, extension kaise ho sakta hai first step? First step is engagement. Engagement happens, it is when the largest transverse diameter crosses the pelvic inlet. At what time does engagement happen in a primary gravida patient? In a primary gravida patient, it happens around 38 weeks. And in a multi-gravida patient, it is going to happen at the onset of labor. Very, very important. My next question to you is, if they ask you that, you find it very useful, Indrajit, I can tell you the mnemonic also. Every decent female I choose to employ rises extremely. That is the mnemonic which I have given in One Touch and in my books. Otherwise, you know, I explain you the movement also. अब बताओ engagement में, if they ask you a question that what is the most common cause of free floating head or non-engaged head, free floating head, या तो क्वेश्चन में दिया होगा फ्री फ्लोटिंग हेड या दिया होगा नॉन एंगेज्ड हेड in a primary at term. So what is the most common cause of free floating head or a non-engaged head in a primary gravida at term? Primary patient में 38 weeks पे engagement हो जाना चाहिए. But if engagement is not happening, then what is the most common cause? Quickly tell me. चलो, NEET PG बच्चाs are going to answer this for me. What is the most common cause? प्राची, यू आर नीट पीजी ना? कपकेक, यू आर नीट पीजी? बताओ आंसर इसका. What is the most common cause of free floating head or non-engaged head in a primary at term? Excellent, Medico 365. It is deflexed head. Please do not say CPD. Krishna, it is not CPD. Shivam, it is not CPD. The answer is deflexed head. अगर deflexed head option में नहीं दिया है, then you are going to mark the answer as CPD. Best answer to this question is deflexed head. Right? You will not mark it as CPD. ठीक है? Okay. And किसी ने placenta previa बोला. अगर CPD नहीं दिया है, then placenta previa. This is the sequence. Most common cause deflexed head, then CPD, and then placenta previa. Right? Now, every descent comes for descent. जैसे ही head of the fetus will come down, descent होगा, तो वहां पे it will meet levator ani muscle. Levator ani muscle उसको push करेगा due to recoil of the muscle. There is going to be flexion. Then there is going to be internal rotation. Tell me, what is the most common position of the fetus at the time of labor? What is the most common position of the fetus at the time of labor? What is most common position at the time of labor? Jaldi batao. What is the most common position at the time of labor? Waiting for your answers. LOT. Excellent. LOT नहीं दिया है, then I am going to mark the answer as LOA. तो LOT पोजीशन से बेबी के हेड को रोटेट करके DOA पोजीशन में आना है. Right? So by how much is internal rotation happening? Internal rotation happens by 2/8 of a circle. From LOT, head of the baby goes to LOA, and then from LOA to DOA. Right? Then C stands for crowning, E stands for extension. With extension, head of the baby is delivered. Then restitution, and then external rotation. ठीक है? So these are the cardinal movements of labor. Just in case you are not understanding, if you are a Marrow subscriber, please go and watch the video. If you are a DBMCI student, after this you can call me, or we can take a Zoom and I'll quickly explain you again these cardinal movements of labor. Chalo, now you are going to tell me, in case of normal delivery, the head of the baby is extending, right, while it is delivering. So WHO ने कहा है कि because जब head of the baby extend करता है, there are high chances of perineal tear. So उस perineal tear को रोकने के लिए, prevent करने के लिए, what are the recommendations which have been given by WHO? Again, very important question. So WHO's recommendations for management of second stage of labor or for prevention of perineal tear. In any of these forms, this question can be asked. So what are WHO recommendations for preventing perineal tear? Number one, WHO says that when you are delivering the head, do not be in a hurry. So you have to do controlled delivery of the head. Do not be in a hurry. Number two, when you are delivering the head, one of your hand should be on the perineum to give the perineal support. So number two is perineal support. Number three, you can take a warm towel and put it on the perineum of the muscle, on the perineum of the patient, so that the muscles relax, right? So number three is warm compress at perineum. You take a warm towel and put it on the perineum, right? So muscles are going to relax, and because muscles are going to relax, the tear is not going to happen. Number four, you can go for a perineal massage, right? SAKSHI, Raj or कौन है प्राची, two things which you never do are episiotomy. One of those things is never episiotomy. WHO does not recommend episiotomy. स्मार्ट सर्जन एपिजोटमी बोलोगे, क्लास में बैठकर भी एपिजोटमी बोलोगे, गलत है ना? ओके, देन नंबर फाइव बताओ, मैंने क्लास में क्या बताया था? शिवम जल्दी बताओ. Last thing which I told you is WHO says कि initially you have to flex the head of the baby. Right, with one hand you are going to flex the head of the baby, and with other hand you will give perineal support. With one hand flex the head of the baby and then extend. Initially flex and then extend. Right, baby ka head is going to be delivered by extension, but initially flex the head so that smaller diameters come out. And what is this maneuver called as? Initially you have to flex the head and then extend, right? Plus you have to give perineal support. This is called as Rittigen maneuver. Very good. It is called as modified Rittigen maneuver. Modified Rittigen maneuver. अब बताओ, what are the two things which are not recommended by WHO? Two things which are not recommended by WHO. Number one, बहुतों ने बोल दिया, episiotomy. Episiotomy is not recommended by WHO. WHO says that every female who is delivering, you don't have to give them an episiotomy. Excellent, Deepak. Second one is fundal pressure. WHO does not recommend fundal pressure. So these are two things which are not recommended by WHO. Now let us quickly revise modified WHO partogram and labor care guide. Now, modified WHO partogram. Just let me quickly show both these partograms to you so that you can remember them. Neet PG Bachas and FMG Bachas, I will be taking your image based session also. And since Neet PG is right in front of us, maybe I take the session today or tomorrow for the image based session. Either I'll take it up today or I'll take it up tomorrow. See here. This over here is modified WHO partogram. Modified WHO partogram mein, please remember that modified WHO partogram is based on previous WHO recommendations, number one. Number two, modified WHO partogram mein, you can see two lines. One is alert line and the other one is action line. The time duration between both of them is 4 hours, right? As you can see in modified WHO partogram, the active phase is going to begin at 4 centimeters and plotting is going to begin at 4 centimeters. Common point about both the partograms, modified WHO partogram and labor care guide is, in both of them cervical dilatation is represented on y-axis and time is represented on x-axis. In both of them, big square का मतलब है 1 hour, small square का मतलब है 30 minutes, right? In both these partograms, we are going to represent the active phase of labor. Latent phase of labor is not represented in both of them. When it comes to labor care guide, in labor care guide, other than active stage or first stage of labor, you also plot second stage of labor. Second stage of labor was not plotted in modified WHO partogram. Number 2 difference. A striking difference between modified WHO partogram and labor care guide is, in labor care guide, there is no alert line, no action line. Third very important difference. In labor care guide, active phase begins at 5 centimeters, and that is why plotting is going to begin at 5 centimeters. In labor care guide also, cervix is plotted on y-axis and time is plotted on x-axis. Again, small squares are going to represent 30 minutes, big squares are going to represent 1 hour. Important point about this alert line and action line is, alert line is based on the principle that minimum dilatation in active phase should be 1 centimeter per hour. It is based on this principle. Whenever you have to do plotting on modified WHO partogram, plotting should begin on the alert line. Plotting should begin on the alert line. Every detail about partogram I have taught to you on the Instagram session. I took an Instagram live session where I have taught you in detail about labor care guide and about modified WHO partogram. I'm not going to repeat it here. I want all of you to watch that Instagram session. If it is not there, if you are not on Instagram, the same session has been put on Telegram also. Again, I'm going to put the link of that session on SSS group and on every group so that you can watch that session. That's a half-an-hour session with every detail about labor care guide and modified WHO partogram. Here, I'll just quickly make you write some important points which are differences between modified WHO partogram and between labor care guide. Modified WHO partogram is based on older WHO recommendations. Labor care guide is based on new WHO recommendations. Right? Now, in modified WHO partogram, we are representing the active phase. We do not represent the latent phase. In labor care guide, we represent the active phase of the first stage of labor plus the second stage of labor. Again, here latent phase is not represented. In modified WHO partogram, active phase begins at 4 centimeters. So plotting is going to begin at 4 centimeters on the alert line. Right? In case of labor care guide, active phase begins at 5 centimeters. So plotting begins at 5 centimeters. Please remember, in modified WHO partogram, alert line and action line, they are present. They are absent in labor care guide, and the time duration between alert line and action line is 4 hours. Right? Other important thing which I want you to remember about modified WHO partogram is that alert line is based on the principle. It is based on the principle that minimum dilatation in active phase should be 1 centimeter per hour. Whereas about labor care guide, I want you to remember that there is a new section which is there, and that new section is about supportive care. And in supportive care, 4 new points are included. Very, very important. Number 1, pain relief. What have I done for pain relief? Number 2, companion, that who is the companion present with the patient, present hai bhi ki nahi hai. Number 3, oral fluid, how much oral fluid is being given to the patient. And number 4, posture. in which posture is the patient lying, whether she is ambulated, whether she is lying in left lateral position, or whether she is lying in supine position. So there is a new section which is included, which is about supportive care, and in supportive care these 4 points are there. Clear to all of you? Yes? So this is what I want you to remember about modified WHO partogram and labor care guide. Other important things are in the live session which I have taken. Then very, very important is what are the steps in active management of third stage of labor. These steps, they should be on your tips. Number 1 step is you have to give injection uterotonic within 1 minute of the delivery of the baby. To whom do you have to give uterotonic? Please remember, you have to give uterotonic to the mother. Don't say I have to give it to the baby, right? Or immediately after the delivery of anterior shoulder of the baby. This is the most important step. The uterotonic which is recommended by WHO is oxytocin, right? So the one which is recommended by WHO is oxytocin. If oxytocin is not available, you are going to tell me what are the alternatives. What are the alternatives if oxytocin is not available? Tell me, if oxytocin is not available, what are the alternative uterotonic drugs which you have to give? Purvasha, I am asking about the alternative uterotonic drugs. Jaldi batao. Methyl ergometrin, Deepak Kumar, very good. Ab batao, methyl ergometrin, can it be given to hypertensive patients or not? Please remember, it is contraindicated in patients with high BP. Right, chalo, methyl ergometrin ho gaya. What is the other alternative? One is methyl ergometrin. Then syntometrin. Very good. Syntometrin. Then which one? Which is the third one? Third one, carbetocin. Excellent. What is carbetocin? Carbetocin is oxytocin analog, synthetic oxytocin. तो बताओ कार्बिटोसिन, अभी कार्बिटोसिन पे रहते हैं. लेट मी जस्ट टॉक अबाउट कार्बिटोसिन. डोज पूछी जाती है कार्बिटोसिन की. What is the dose of carbetocin used for AMTSL? Very, very important. Purvasha, very good. It is contraindicated in topper, methyl ergometrin. Yes. Tell me, what is the dose of carbetocin? Where is my smart surgeon? Batao, what is the dose of carbetocin? I have taught you in class. 100 micrograms. Excellent. 100 milligram नहीं है, 100 micrograms है slow IV. Then next is mesoprost. Excellent. बताओ mesoprost की dose for AMTSL. Dose of mesoprost for AMT. जितने लोग 100 milligrams लिख रहे हैं, please remember it is 100 micrograms IV, slow IV. Mesoprost. Dose of mesoprost for AMTSL. 800 micrograms. कृष्णन सोचो फिर से. 800 micrograms. AMTSL के लिए 800 micrograms. 600 micrograms. Very good. 600 micrograms. Yes. अब बताओ. So many of you were saying carboprost. Please remember, carboprost is not used in management of AMTSL. Carboprost is a drug जिसको reserve करके रखा है for management of PPH. Please do not say carboprost. Carboprost is not used for AMTSL. जितने लोग carboprost बोल रहे थे, please highlight this point in your notes. Carboprost is not used for AMTSL. It is reserved for PPH. ठीक है? Okay. Then second is delayed cord clamping. That is clamping the cord within 1 to 3 minutes of delivery. Fourth step is delivery of the placenta by controlled cord traction. अब controlled cord traction की image बहुत बार पूछी जाती है. In which, what is controlled cord traction? With one hand you will push the uterus up and back, and with the other hand you are going to give traction to the cord in downward and forward direction. Yes, Pratyusha, carboprost is not used in management of AMTSL. It is used in management of PPH. ठीक है? स्मार्ट सर्जन, व्हाट इज गिवन रॉन्ग इन वर्कबुक? बताओ क्या गलत दिया है वर्कबुक में? क्लास अटेंड नहीं करोगे और केवल वर्कबुक में बाकियों की वर्कबुक देख के मार्क करोगे तो कभी भी नहीं आएगा ना. यू वर नॉट देयर इन द क्लास. आई रिमेंबर जब 4 दिन की क्लास हुई थी, यू वर द वन हु यूज्ड टू कम लेट. सो क्लास में आई हैव टोल्ड यू दैट कार्बोप्रोस्ट इज नॉट यूज्ड इन मैनेजमेंट ऑफ AMTSL. ठीक. Then, number 4, intermittent assessment of uterine tone. Intermittent assessment of uterine tone. This is the 4th step nowadays. Earlier, the 4th step was uterine massage. Please remember, early cord clamping is not a part of AMTSL. Right? Early cord clamping is not a part. Very, very important thing. Early cord clamping is not a part of AMTSL. ठीक? Now, what are the conditions in which conditions you do early cord clamping? चलो फिर you would be present in class. My bad. ठीक है? My bad. I didn't see you. You were there in class. I take my words back. चल. अब पढ़ाई पे ध्यान दे दे. ओके. कंडीशंस ऑफ अर्ली कॉर्ड क्लैंपिंग. Where do you do early cord clamping and what is early cord clamping? Early cord clamping is when you clamp the cord within 1 minute of delivery. That is early cord clamping, and early cord clamping is not done in every case. Early cord clamping का absolute indication is whenever neonatal resuscitation is needed. जब भी बेबी को रिससिटेशन की जरूरत होती है, देन यू हैव टू गो फॉर अर्ली कॉर्ड क्लैंपिंग. फॉर एग्जांपल, बर्थ एस्फिक्सिया. So if they ask you one condition where early cord clamping is required, one condition where early cord clamping is required is neonatal resuscitation. अगर neonate को resuscitation की जरूरत है तो I'm not going to tell the pediatrician कि रुको, just wait, I want that extra blood to come to the fetus. I'm not going to do that, right? Then when is early cord clamping required? Birth asphyxia, because birth asphyxia में the baby requires neonatal resuscitation. Then if the baby is a known case of congenital heart disease, if baby is a known case of congenital heart disease, that extra 80 ml of blood, why I was doing in delayed cord clamping? Because that extra 80 ml of blood, it goes to the fetus and it can prevent anemia. अब that extra 80 ml of blood can precipitate heart failure if baby is a known case of congenital heart disease, and in case of RH negative females. RH negative females में अगर कुछ नहीं दिया and they simply ask you which type of cord clamping has to be done, please remember it is early cord clamping. But as I told you, absolute indication, one indication where you have to do early cord clamping is wherever baby requires neonatal resuscitation. Right? Now, when it comes to HIV positive females, till now the Government of India guidelines were saying that we have to go for early cord clamping. But now, whether it is NACO guidelines, whether it is WHO guidelines, everyone is saying that in HIV positive you have to do delayed cord clamping. So I want all of you to write this: delayed cord clamping. By NACO also has changed its guidelines and it is delayed cord clamping. Right? Now, whether they ask you HIV positive females, whether they ask you COVID positive females, whether they ask you macrosomia, कुछ भी they try to confuse you. In every case, you have to do delayed cord clamping. These are the only conditions where you have to do early cord clamping. Please remember, delayed cord clamping is also a part of Anemia Mukt Bharat program. It's a part of Anemia Mukt Bharat program. So in Anemia Mukt Bharat program, to prevent neonatal anemia, what is recommended by Government of India? Delayed cord clamping is recommended by Government of India, right? Now, in case of drugs, as I told you, oxytocin is the drug of choice or the uterotonic of choice for AMTSL. Other than that, you can use methyl ergometrin. Methyl ergometrin के अलावा synthometrin, carbetocin, which is 100 micrograms slow IV. You can use misoprost, that is 600 micrograms, right? Please remember, carboprost is used for management of PPH and not for AMTSL. Clear? Coming to steps in management of PPH. First tell me, how do you define PPH? PPH is blood loss more than equal to 500 ml after vaginal delivery or more than 1000 ml after cesarean section. Right? Now, PPH can be primary PPH or it can be secondary PPH. What is primary PPH? What is primary PPH? What is primary PPH? When PPH happens within When PPH happens within 24 hours. Excellent. Within 24 hours, that's primary PPH. What is secondary PPH? Secondary PPH is if it is happening after 24 hours and up till 12 weeks of delivery. Up till 12 weeks of delivery, that is secondary PPH. Most common cause of primary PPH is atonic uterus. Most common cause of secondary PPH is retained tissue, that is retained placenta. Now, please remember, risk factors for PPH are very important. I know most of you will remember polyhydramnios, twins, then multigravida females, all of this you will remember. I want you to remember some of them क्योंकि confusion इनमें होता है. Please remember PIH. PIH is a risk factor for PPH. Antepartum hemorrhage is a risk factor for PPH. Placenta accreta is a risk factor for PPH. Chorioamnionitis is a risk factor for PPH. Excessive use of oxytocin या excessive use of general anesthesia is a risk factor for PPH. Rest I know all of you know, remember the other ones. These are the ones जिनमें confusion होता है. I am not giving you the entire list because बाकी I know you remember. Right? Prolonged labor, instrumental delivery, macrosomia, all this you remember. These are the ones which you tend to forget. So I am just writing the ones which you tend to forget. Take? So yes, these all can lead to PPH. Now, what are the steps in the management of atonic PPH? In steps in the management of atonic PPH. Now, steps in the management of atonic PPH. सबसे पहले, once you are sure that you are dealing with atonic PPH, first thing what you have to do is a bimanual massage. Now please remember, PPH is an obstetrical emergency and ये ऐसी emergency है जिसमें the same steps have to be followed which I am going to tell you. Right? You are going to follow the same steps in which I am going to make you write. So you will do a bimanual massage. You cannot do it alone, na? एक team work होगा. One of you will be doing a bimanual massage. Other one will be doing maternal resuscitation. Bimanual massage, maternal resuscitation, plus simultaneously you will start tranexamic acid and oxytocin. Tranexamic acid and oxytocin. So do a bimanual massage, do maternal resuscitation, simultaneously start tranexamic acid and oxytocin. When you are doing maternal resuscitation, you are going to put 2 large bore IV cannulas. That is cannula number 14 and cannula number 16. You are going to start with crystalloids. You are going to send all blood investigations. You are going to arrange for blood. All these steps I am going to do, and simultaneously tranexamic acid and oxytocin. Now, if this is going to fail, after oxytocin, so oxytocin is again what is recommended by WHO. It is recommended by WHO. If oxytocin, and yes, it has to be 20 to 40 international units of oxytocin. Now, if it fails, what is the next drug? After oxytocin, which drug are you going to try? After oxytocin, which is the drug which I am going to try? Prachi, yes, the large bore IV cannulas are cannula number 14 and 16. Very good. अब बताओ ऑक्सीटोसिन के बाद कौन सी ड्रग ट्राई करोगे? If oxytocin fails, which drug are you going to try? You are going to try methergin. That is methyl ergometrin. If oxytocin fails, then which other drug? If methergin fails, then carboprost. In this sequence, you have to try the drugs: oxytocin, methergin, and carboprost. Right? Now, what is the dose of carboprost? 250 micrograms. Maximum how many times? And this has to be given IM. Maximum carboprost kitna diya ja sakta hai? How many times you can repeat it? You can repeat it after every 15 to 90 minutes. And maximum how many times you can repeat it? 250 micrograms, maximum 8 doses. Very good. That means how many milligrams? 2 milligrams. So the dose of carboprost is 250 micrograms. It can be repeated after every 15 to 90 minutes. Maximum you can give 8 doses. That is, you can give 2 milligrams. Right? Okay. Please remember, carbetocin is not used in PPH. जैसे carboprost was not used in AMTSL, carbetocin is not used for managing PPH. याद रहेगा सबको? Okay. Now, if you are going to try this for 30 minutes, all this has to be tried for 30 minutes. If this fails, then you are going to go, as I always tell you in class also, suppose your roomie falls down and there is a wound which is there, bleeding is happening from the temple. What are you going to do? You are going to press the forehead, right? I was trying to press the uterus with my hand. If I am unable to press the uterus with my hand, now my next step is, let me try some catheter which I am going to inflate and put it inside the uterus. Maybe the bleeding stops, and that is what is called as balloon tamponade. Balloon tamponade. Mechanical compression by using balloon tamponade. What are you going to use over here? You are going to use Buckley balloon catheter. Buckley balloon catheter. They ask you what is the maximum capacity of Buckley balloon catheter. It is 500 ml. Right? Now, if this is also going to fail, you tell me, if by pressure the bleeding doesn't stop from the forehead of your roomie, what do? You immediately take her to the emergency so that stitches can be applied. Now, same thing I am going to do. Alita, Preeti se kehna pani de degi, please. Now, same thing I am going to do over here. Over here, I am going to put stitches on the uterus. I am going to shift my patient to OT. I am going to do a laparotomy, take out the uterus, and then apply stitches on the uterus, which is called as B-link suture. I will apply B-link suture, which are the compression sutures. These are compression sutures, right? Now, if this also fails, then I am going to do stepwise devascularization. stepwise devascularization. That means I am going to stop the blood supply to the uterus. Stop the blood supply to the uterus. To stop the blood supply to the uterus, I am going to do what? I am going to do uterine artery ligation, because uterus is supplied by uterine artery. First of all, major part of the uterus is supplied by uterine artery. Other than that, which artery? Ovarian artery ligation. Ovarian artery ligation. Right? Now, once I have done this and still the bleeding is not stopping, if the bleeding doesn't stop, now also the bleeding doesn't stop, then I am going to see whether the vitals of my patient are stable or not. If vitals of my patient are stable, I am going to go for internal iliac artery ligation. Not the entire, only the anterior division. The ligation of the anterior division of internal iliac artery. Why division of the anterior division of internal iliac artery? Because uterine artery is a branch of anterior, bottle hi rakh dena please. Uterine artery is a branch of anterior division of internal iliac artery. Right? But if the vitals of my patient are unstable, I will immediately take her up for hysterectomy. Which hysterectomy? Subtotal hysterectomy. In subtotal hysterectomy, you are removing the uterus, not the cervix. You remove the uterus, not the cervix. It's not unstable hysterectomy, it's subtotal hysterectomy. You have to remove the uterus, not the cervix. Clear to all of you? Yes? Done? Have you understood how to manage stepwise management of PPH? Okay. Next important question which they ask you is on postpartum collapse. Now, postpartum collapse pe they have started asking you questions recently, and many questions are being asked, whether you are a Neet PG aspirant or whether you are FMGE aspirant, questions are asked. If they ask you what is the most common cause of postpartum collapse, most common cause of postpartum collapse is PPH. Right? Everything about PPH I have told you. But see, in PPH, there has to be significant blood loss. Then only patient is going to collapse. Right? In PPH, it is never going to be this that patient immediately goes into shock after delivery. That kind of a thing is not going to happen. Patient is going to have bleeding, and there will be significant bleeding, and then only patient will collapse. But suppose if your question says that there is immediate shock after delivery. Now, whenever their question says immediate shock after delivery, that means you are dealing with uterine inversion. Then you are dealing with uterine inversion. Uterine inversion. Now, in a case of uterine inversion, if these are the supports of the uterus, and this is normally how the uterus is present, in uterine inversion, the uterus will invert and it will be like this. Or, you know why uterine inversion happens? Because just now the placenta was not separated and I have pulled the cord. Right? I have pulled the cord, the placenta was not separated. So either the fundus of the uterus will dip or the entire fundus of the uterus will come out. Right? Both these are uterine inversions. Now, all of you know, where is the uterus present immediately after delivery? Uterus is present immediately after delivery at the level of, just below the level of umbilicus. So, जब भी uterine inversion होगा and I am going to do a per abdominal examination, I am going to get a cup-like depression just below the umbilicus. So, there will be a cup-like depression just below the umbilicus. देखो यूट्राइन इन्वर्जन ना कभी भी अपने आप से नहीं होता. It is mismanaged third stage of labor जिसकी वजह से होता है. You have pulled the cord, the placenta was not separated, you have pulled the cord and patient will immediately go into shock. Why? Because of neurogenic shock. Initial shock in uterine inversion is neurogenic. So neurogenic shock hota hai and patient immediately goes into shock. On per vaginal examination, you are going to get a globular mass felt inside the vagina. Right? So if you are getting a situation like this, that the question says there is immediate shock after delivery, on per abdominal examination, there is a depression, cup-like depression just below the umbilicus, or you get a globular mass which is felt inside the vagina, that means you are dealing with uterine inversion. Two questions in uterine inversion. Number one, immediate shock of the patient is due to. Immediate shock is neurogenic. But death of the patient is due to hemorrhagic shock. Initially, it is neurogenic shock. Once the uterus hangs out, the tone of the uterus is lost and then it gets converted into hemorrhagic shock. And death of a patient occurs due to hemorrhagic shock. Next, if your question says that there is sudden unexplained shock and patient is complaining of breathlessness, that is respiratory difficulty. या तो breathlessness लिखा होगा in your question, या respiratory difficulty लिखा होगा in your question, या hypoxia लिखा होगा in your question. Right? Along with that, patient has shock. Along with that, later on, there is DIC. Initially, there is less bleeding, but later on, there is DIC. Then you are dealing with amniotic fluid embolism. Amniotic fluid embolism. In amniotic fluid embolism, per abdominal and per vaginal examination are normal. Please remember, in amniotic fluid embolism, initially there is less bleeding, right? Initially there is less bleeding. Later on, due to DIC, there is going to be excessive bleeding. So your question is going to say that patient was in shock. You have delivered a patient and patient goes into shock. There is respiratory difficulty, right? And their patient is in shock. The question can say less bleeding or question can say DIC, right? Either of these two things question can say. Per abdominal everything is normal, per vaginal everything is normal. That means you are dealing with amniotic fluid embolism, right? Now, next question. Next question is, if your question says that there is a patient who's complaining of pelvic pressure, severe pain and difficulty in passing urine after delivery. All this is happening after delivery. After delivery, patient is having some sort of pelvic pressure or she is having severe pain and there is difficulty in passing urine. What is your diagnosis? Batao, what is your diagnosis? Excellent, Monica. The answer is hematoma, and because most common is vulval hematoma, I'm going to take it as a vulval hematoma. It could have been a vaginal hematoma, but most commonly you get a vulval hematoma. Vulval hematoma mein which artery is involved? This hematoma is going to be seen in which artery? What is the blood supply of the perineum? Blood supply of the perineum is pudendal artery, right? So the artery which is involved is pudendal artery. Okay. Now, that is how a patient is going to present to you with there is pelvic pressure or severe pain, difficulty in passing urine. right? And this is how the patient is going to present to you. So you should immediately come to know that you are dealing with vulval hematoma. How do you manage a vulval hematoma? What is the management of vulval hematoma? Vulval hematoma has to be managed conservatively. It has to be managed conservatively with ice packs and analgesics. But there are certain conditions where you have to go for surgical management. What are the indications for surgical management? The indications for surgical management are if your patient is having severe pain, if the size of the hematoma is increasing, or if your patient goes into shock. Because if their patient is going into shock or if the size of the hematoma is increasing, that means there is an active bleeder present. And so I will have to do an incision and drainage of the hematoma. I will have to ligate the bleeder and I will have to close the cavity of the hematoma. That is what I have to do if my patient is going into shock, or if the size of the hematoma is increasing, or if there is severe pain. Clear to all of you? Yes? Now, next important point is they ask you questions on perineal tears. So, what are the important points on perineal tears? On perineal tears, they ask you the grading of perineal tear. In grading of perineal tear, please remember, grade 1 perineal tear means if the tear is involving only the vaginal epithelium or the perineal skin. If muscles are involved, skin के साथ साथ muscles involve हो गए, then that means it's grade 2 tear. Grade 3 tear का मतलब है, third degree tear का मतलब है whenever anal sphincter is involved. So first degree tear means only the skin or the mucosa is involved. Second degree tear का मतलब है along with skin or mucosa the muscles are involved. Third degree tear का मतलब है the anal sphincter is involved. It can be A, B or C. A का मतलब less than 50% of anal sphincter involved. B का मतलब more than 50% of anal sphincter involved. And C का मतलब internal anal sphincter involved. A and B are less than 50% of external anal sphincter. B is more than 50% of external anal sphincter. And C is when internal anal sphincter is involved. 4 degree perineal tear, what do you mean by 4 degree perineal tear? 4 degree perineal tear means when rectal mucosa is involved, right? Next, please remember, 3rd degree and 4th degree perineal tears, they are called as complete perineal tears. 3rd degree and 4th degree perineal tears, they have to be repaired in OT under general anesthesia. Whereas 1st degree and 2nd degree perineal tear, they are like episiotomy and they have to be repaired in labor room under local anesthesia, right? So please remember the grading of perineal tears. I have also told you what are WHO recommended methods to prevent perineal tear, which are very, very important. Next important topic for all of you is related to episiotomy. So they ask you questions, many questions related to episiotomy. So if this over here is the introitus, that is the opening of vagina, this is the anal sphincter, this is the opening of vagina. Now we all know muscles are present over here. Right? Now, when you are giving an episiotomy, either you can give an episiotomy like this, that is a median episiotomy, or you can give an episiotomy at an angle, that is mediolateral episiotomy. Right? Please remember, mediolateral episiotomy. इसका angle क्या होता है? The angle of mediolateral episiotomy? Angle of mediolateral episiotomy is 60 degrees. Right? Range is 45 to 60 degrees. Now, when you are giving a mediolateral episiotomy, the important point is that more muscle fibers are cut. When you are giving a median episiotomy, this is median and this is mediolateral. When you are giving median episiotomy, the important point is that less muscle fibers are cut. Now, because in case of median episiotomy, less muscle fibers are cut. right? Because जितने muscle fibers होते हैं ना, they are maximum at the sides and by the time they come in the center, muscle fibers less होते हैं. तो median episiotomy में always less muscle fibers are cut. Mediolateral episiotomy में always more muscle fibers are cut, right? Now, because in median episiotomy less muscle fibers are cut, that is why bleeding is less. That is why repair is easy. That is why healing is fast. That is why chances of gaping of the episiotomy are less. And that is why pain at the time of intercourse, that is dyspareunia, will be less. All these things are more in mediolateral episiotomy because more muscle fibers are cut, right? More muscle fibers are cut, तो बहुत सारा bleeding होगा patient को, repair भी difficult होगा, healing भी delayed होगा, healing delayed होगा तो chances of gaping ज़्यादा होगा, dyspareunia भी ज़्यादा होगा, right? So that is why अब सुनने में तो ऐसा लग रहा है कि मैम then तो median episiotomy is very good, but why is it कि अपनी labor rooms में we have seen mediolateral episiotomy being done, right? तो अब बताओ why is it mediolateral episiotomy is preferred over median episiotomy? ऐसा क्यों हो रहा है कि इतने सारे advantages हैं median episiotomy के, but still I am preferring mediolateral. That is only because of one reason. If while doing delivery I am not careful, right? If while delivery I am not careful, in median episiotomy I will be tearing the anal sphincter. I will be damaging the anal sphincter. But in case of mediolateral episiotomy, no matter how much I extend, I will never be able to injure the anal sphincter. So imagine an obstetrician conducting a normal vaginal delivery and leading to injury of anal sphincter, making a patient fecal incontinent after delivery. That's the worst thing what you can do. पूरे दिन न्यूज में आप छाए रहोगे for all bad reasons अगर आपने ये कर दिया तो, right? And that is why we don't prefer median episiotomy. The biggest disadvantage of median episiotomy is it can extend and involve anal sphincter. Whereas the biggest advantage of mediolateral episiotomy is it can never involve anal sphincter. ठीक है? All of you got this? So same thing I have written over here. Advantages of mediolateral episiotomy, even if it extends, it cannot involve anal sphincter, right? Disadvantage of mediolateral episiotomy, I have written here. Now, as I told you that WHO said कि you should not be giving episiotomy in every female who is undergoing vaginal delivery. Every female who is undergoing vaginal delivery में episiotomy नहीं करनी है. But जहाँ indicated है वहाँ करनी है. What are the indications? Indications are for after coming head of breech, instrumental delivery, macrosomia, shoulder dystocia, इन सब में तो करनी है, right? Clear? Now, then they ask you all of the following muscles are cut in episiotomy except. Now, I don't want you to remember the structures which are cut in episiotomy. I want you to remember the muscles which are not cut in episiotomy क्योंकि उस except का आंसर उस not में से आएगा. So, all those muscles जो side में present होते हैं, please see over here, जो भी muscle center में होगा that is going to be cut. Muscles which are there on the side will never be cut. Yes, smart surgeon, अगर hydrocephalus है, देखो बेटा, wherever you are thinking कि perennial tear can happen, whether it is macrosomia, whether it is hydrocephalus, whether it is rigid perineum, you have to do episiotomy, right? WHO is not saying कि करते ही नहीं है episiotomy. WHO कहता है अगर indicated है तो करो, But if it is not indicated, then don't do, right? Okay. So now telling you what are the muscles which are present towards the side. Muscles which are present, yes Vijay, the muscles which are present towards the side are ischio wale muscles. And as I always tell you, ischio-coccygeus, ischio-cavernosus. Ischio-coccygeus की जगह पे they can also write simply coccygeus. Then obviously anal sphincter is not torn and obturator internus is not torn, right? So ischio wale muscles are not cut during episiotomy. Ischio-cavernosus, ischio-coccygeus, right? All of you should remember that levator ani is made up of only two muscles, pubococcygeus and iliococcygeus. Clear? Right. So this is about episiotomy. Abhi yahan tak any questions do you have? Any questions which you have till here? Any one of you? Any of you have any questions till here? I know I'm going a little fast because this is a revision class. So revision class में थोड़ा तो fast होना बनता है. Okay. No questions? Manoj, you can get the PDF. The empty PDF, the blank PDF is there on the SSS group and on the CTG group. And this annotated PDF, again, I'll... अभी आने दो विजय, let me come. मुझे scores में आने तो दो, अभी मैंने पढ़ाया कहाँ है? I have not taught you the scores just now, na? Let me come to the scores. PDF is there on SSS group and on the CTG group. SSS study with Dr. Sushil and Dr. Sakshi. This is there on your Telegram group. Atul, there is nothing like a J-shaped cut. We don't do anything like that. Right? Gynae I will be taking single session. लंबा session होगा, 3 to 4 hours का session होगा, speed यही होगी. ठीक है? Okay. Now, coming to important points on malpresentation. What is the most common malpresentation? Most common malpresentation is breach. Now, if they ask you what is the most common cause of breach or transverse lie, transverse lie mein what is the presentation? What is the presentation in transverse lie? Who's going to ask? Who's going to answer? What is the presentation in transverse lie? Shoulder presentation. Right? So, if they ask you what is the most common cause of breach or what is the most common cause of transverse lie, what is your answer? Answer is preterm delivery or prematurity. Prematurity. See, all the babies automatically rotate between 32 to 34 weeks. So, before 32 to 34 weeks, जितने भी babies breach में होते हैं, जितने भी baby transverse lie में होते हैं, they will automatically rotate and they are going to become cephalic. But if this auto rotation doesn't happen, why will this auto rotation not happen? Because delivery happened before 32 to 34 weeks. So, the most common cause of breach or transverse lie is prematurity or preterm labor. Now, whenever a breech patient or transverse lie patient comes to us in antenatal period, I have to try external cephalic version. What do you mean by external cephalic version? External का मतलब per abdominally I will rotate. So, per abdominally I will rotate the fetus and we will make it cephalic. That is what is meant by external cephalic version, right? Now, this can be done only if the baby is breech or transverse lie, and this can be done only if it is a single pregnancy. It cannot be done in twin pregnancy. Time for external cephalic version. Time for external cephalic version is more than 36 weeks. You can do it any time after 36 weeks. Best time 37 weeks. Best time 37 weeks. I have written more points on external cephalic version or no? Acha. I want you to add a few more points on external cephalic version. So on external cephalic version, please write the prerequisites. Prerequisites for external cephalic version, it should be that it has to be a singleton pregnancy. You cannot do it in twin pregnancy. Number 2, amniotic fluid should be adequate. When I'm saying amniotic fluid should be adequate, that means membranes should not be ruptured. Membranes should not be ruptured. Number 4, it cannot be done in active phase of labor. But please remember, it can be done in latent phase of labor. Next important point is, it should not be done in any condition where vaginal delivery is contraindicated. For example, in contracted pelvis. अब अगर pelvis contracted है तो whether it is cephalic or whether it is breech, you have to do a cesarean section. For example, placenta previa. Right? So these are the things which you have to keep in mind before you do external cephalic version. It is done in OPD. It is done under CTG guidance, or right, it has to be done under CTG guidance, and you can give terbutaline to the patient for uterine relaxation. Uterus को relax करने के लिए you can give terbutaline. Next important point is external cephalic version is relatively contraindicated in VBAC patients, in cesarean section patients. In cesarean section patients. External cephalic version is not an absolute contraindication in cesarean section patients. Internal podalic version is absolutely contraindicated in cesarean section patients. What were the conditions in which condition were you doing internal podalic version? Last time I told you, internal podalic version, it is done in twins when the second twin is transverse lie. Right? It is done under general anesthesia in OT. So this is what is internal podalic version and external cephalic version. In internal podalic version, you are taking your hand inside the uterus, you are holding the leg of the baby and you are rotating the baby. Right? So that is what you have to remember about external cephalic version. Then next important point, if they ask you what is the management of occipito-posterior position, very very important, please say that I am going to wait and watch. Why? Because baby automatically rotates. Baby automatically rotates by 3/8 of a circle. Why? So please remember, यहाँ आओ, ये देखो. Most common occipito-posterior position. Most common occipito-posterior position is ROP position. अब ROP position से baby ने DOA position पे आना है, right? So baby will have to rotate from ROP position to ROT position, from ROT to LOA and then DOA. 1/8, 2/8, 3/8. So how much does a baby have to rotate? So baby has to rotate by 3/8 of a circle. Baby automatically rotates by 3/8 of a circle. It becomes DOA and vaginal delivery occurs. But because baby has to rotate by 3/8 of a circle, So it is going to take time, and the only thing as an obstetrician I have to do is to have patience, that is wait and watch. Wait and watch. So if your question says that a baby is in occipito-posterior position, what do you have to do? You have to wait and watch. Now, if your question says that baby started rotating and it started rotating from ROP position, it came to ROT position and then it stopped there. It did not rotate any further. Right? So occipito-posterior say it became occipito-transverse, but occipito-transverse ke aage rotation did not happen. Right? Then this is called as deep transverse arrest. Ab deep transverse arrest pe the questions which they ask you is, number one, what is the best management of deep transverse arrest? Please remember, best management of deep transverse arrest is cesarean section. Next, what is the most common pelvis जहाँ पे deep transverse arrest is common? So deep transverse arrest is most common in android pelvis. Why? Because this is the only pelvis जहाँ पे ischial spines prominent होते हैं. And remember, deep transverse arrest हो या internal rotation हो, both of them occur at the level of ischial spine. So deep transverse arrest and internal rotation, they occur at the level of ischial spine. What is the best management? Best management is cesarean section. Right? Now, my next question to you is, your question says, and this is a question which was recently asked in Neet. Your question says that there is a pregnant female with infraumbilical flattening. She has infraumbilical flattening plus the fetal heart sounds, they are heard in the sides of the mother, in the flank area of the mother. What is your diagnosis? What is the diagnosis? This is case number 1. Case number 1. What is your diagnosis? There is a pregnant female with infraumbilical flattening and fetal heart sounds heard in the flank area of the mother. Excellent, Shivam. It is occipito-posterior position. Occipito-posterior position. Now coming to case number 2. Excellent, all of you. There is a pregnant female in whom when we did Leupold first maneuver, it was empty, and Leupold's fourth maneuver was empty. Height of the uterus is less than POG. What is your diagnosis? Height of the uterus less than POG. This is your case number 2. Leupold's first maneuver empty, Leupold's fourth maneuver empty, and height of the uterus less than POG. Fundal grip, yes, Leupold's first maneuver is fundal grip. Instead of this, they can write fundal grip, empty. What is your diagnosis? Excellent, Karthik, Titir, Nivetha. It is transverse lie. Please understand, in transverse lie, when you are palpating the fundal area, it will be empty. When you are palpating the pelvic area, it will be empty. And height of the uterus will be less than POG. Right? So these are the clinical questions which they are asking these days. Right? They can ask you these questions oftenly. My next question, What is the management of transverse lie? Whether the baby is dead or whether the baby is alive, management of transverse lie always is cesarean section. In antenatal period, I can try external cephalic version, right? In antenatal period, external cephalic version, but otherwise there is going to be the management is cesarean section. Now, if they ask you what is the management of obstructed labor, obstructed labor पूछ सकते हैं, या obstructed labor की जगह they can give you hints like a Bandel's ring is present. Where is a Bandel's ring present? Bandel's ring is present between upper uterine segment and lower uterine segment, right? So whenever they are saying obstructed labor, please do not say instrumental delivery. Obstructed labor means you have to do cesarean section. Now, next important point. If your question is saying that there is CPD, there is caput or there is molding. If your question says that there is caput or molding and there is slow progress of labor, caput or molding along with slow progress of labor, right? Slow progress of labor means dilatation of the cervix is less than 1 centimeter per hour. Caput or molding along with slow progress of labor means your patient is having CPD. The diagnosis is CPD and management is cesarean section. These are the hints which you are going to look in your question, because these days they are asking you what is the next step or what is the management. Management ke questions ke liye you have to remember this, that whenever your question says that there is CPD, there is caput or molding along with slow progress of labor, it means they are talking about cephalopelvic disproportion, and whenever there is cephalopelvic disproportion, you have to do cesarean section. Now, if your question says that there is fetal distress in first stage of labor, what I want all of you to understand before I talk to you about fetal distress is a few important things about forceps and vacuum. Please remember, forceps and vacuum की prerequisite क्या है? Prerequisite for forceps and vacuum is that the cervix should be fully dilated. Number 1. And number 2, the station of fetal head should be more than equal to +2. In other words, +2, +3, +4, +5. इनमें से कुछ होना चाहिए. You cannot apply forceps or vacuum if the station of fetal head is above +2, right? And you cannot apply forceps or vacuum unless and until the cervix is fully dilated. And cervix will be fully dilated in second stage of labor. This means I can apply forceps and vacuum only during second stage of labor and not before that, right? That is why whenever fetal distress is happening in first stage of labor, the only option which I have is cesarean section. But if fetal distress is happening in second stage of labor का मतलब is cervix is fully dilated. In this case, in the question, you have to look for the station of fetal head. Agar station of fetal head is above +2. If station is above +2, go for cesarean section. And if station is below +2 or at +2, then you have to apply forceps. Then it's better to apply forceps. Please remember, fetal distress के case में forceps are better than vacuum, right? So the only thing what I have to keep in mind is whether the station is above +2 or whether the station is at or below +2. Clear? Yes. So this is how you manage your questions whenever question come on fetal distress. Is this point clear to all of you, how you are going to manage questions related to fetal distress, obstructed labor, CPD? How are you going to answer them? All of you, have you understood? Yes? Okay. Now, what are the conditions where you have to do only cesarean section in case of malpresentations? So in case of malpresentations, you have to do cesarean section in transverse lie. It can be transverse lie or shoulder presentation. Anything can be given to you. In transverse lie or in shoulder presentation, whether the baby is alive or whether the baby is dead, you have to go for cesarean section. Then in case of bro presentation, then in case of face, in mento posterior face presentation, in mento anterior face presentation, vaginal delivery can be done. Only in mento posterior you have to go for cesarean section. Then in breech, if it is foot link presentation, then you have to do cesarean section. If it is knee presentation, then you have to do cesarean section. And if it is a stargazer breech. Now, what is a stargazer breech? I told you, normally all parts of the baby are flexed. So in breech also the head of the baby is flexed. But in breech, if the head of the baby is extended, it appears as if it is counting the stars, and that is what is called as stargazer breech presentation. So in stargazer breech presentation, you have to do a cesarean section. Clear? Now, next questions which they ask you are beta on vacuum and forceps. In vacuum and forceps, I want you to remember about forceps. Number one point about forceps, other than prerequisites all of you should remember. Other than prerequisites, you have to remember forceps can be used in all those presentations. Where cesarean is not mandatory. Right? So where cesarean section is not mandatory, in all those conditions you can use forceps. For example, you can use forceps in vertex presentation. For example, you can use forceps for delivering the after coming head of breech. You can use forceps in face that is mento anterior. Right? But then next important point about forceps. Next important point about forceps is that forceps cannot rotate the head of the fetus. Third important point about forceps is if you are applying forceps, when you apply forceps at +2 or +3 station, then that is called as low forceps application. Right? Low forceps application. And if you are applying forceps at +3, +4 या +5, that is called as outlet forceps application. आउटलेट फॉर्सेप्स का एक ही एग्जाम्पल होता है रिगलीज फॉर्सेप्स. So whenever you apply forceps at +2 or +3 station, that is low forceps application. When you apply forceps at +3, +4 या +5, that is outlet forceps. Outlet forceps का एक ही example है, that is Wrigley's forceps. Clear to all of you? Now understand one more thing. This time in Neet they asked a question that head of the baby is at +3 station, right? Now tell me, if head of the baby is at +3 station, which forceps am I going to apply? Because low forceps भी +3 पे लगता है and outlet forceps भी +3 पे लगता है. In that case, you have to look +3 के साथ if they have said that its sagittal suture is in AP diameter. अगर ये लाइन दी है sagittal suture in AP diameter, sagittal suture in AP diameter, then it means it is outlet forceps, right? So I'm writing this line properly because this line is actually very, very important. If your question is saying sagittal suture in AP diameter, then in that case you are going to apply outlet forceps, right? So please remember station +2 है या +3 है low forceps, +3, +4, +5 outlet forceps, +3 में if this line is given sagittal suture AP diameter, then mark the answer as outlet forceps. अगर ये line नहीं दी है, then mark the answer as low forceps. Clear to all of you? Yes. Then important point about vacuum. About vacuum, the good point is that number one, it can rotate the head of the baby. It can rotate the head of the fetus. Number two, although I'm not going to use it, but it can be applied. Please remember, जो vacuum का cup होता है ना, उसका diameter is 6 centimeters. So the moment cervix is dilated to 6 centimeters, I can apply vacuum. So it can be applied if cervix is more than equal to 6 centimeters dilated. I am not going to apply it, but it can be applied theoretically. Number 3, it cannot be used. Where can you not use vacuum? Number 1, it cannot be used in preterm babies. Number 2, because the head of the baby is very soft. अगर आपने बेबी के हेड पे वैक्यूम लगाया प्रीटर्म बेबी के, then there are increased chances of intracranial hemorrhage, right? Number 2, it cannot be applied for after coming head of breech. It cannot be applied in face presentation, right? In all these conditions you can apply forceps, but you cannot apply vacuum. Clear to all of you? Yes. Last point which I want you to remember, in PIH, in heart disease of the mother, right, and in fetal distress, forceps is preferred over vacuum. I am not saying that vacuum cannot be applied, but forceps is preferred over vacuum in PIH, in heart disease of the mother, and in case of fetal distress. Clear? So this is about forceps and vacuum. Coming to your question, which was FMGE 2023 question, and that is why I have taken up forceps and vacuum in detail. Ventouse. Remember, ventouse is the other name for vacuum. Vacuum is contraindicated in. So it is contraindicated in premature babies, right? In maternal heart disease, I prefer forceps, but that doesn't mean that vacuum is contraindicated, right? Fetal distress may we are you preferring forceps, but that doesn't mean that it is contraindicated. Okay. Coming to cesarean section. Now, whenever I am doing cesarean section, And if I am giving a incision on the upper uterine segment, then that is called as classical cesarean section. It is called as classical cesarean section. Now, in case of classical cesarean section, the chances of rupture are high. That is why in next pregnancy you have to do cesarean. Right? Vaginal birth cannot be tried. Vaginal birth cannot be tried. But when you are giving incision in the lower uterine segment, that is called as lower segment cesarean section. In lower segment cesarean section, you want to know the pressure? So initial pressure in vacuum is 0.2 kg per centimeter square. Initially it is 0.2 kg per centimeter square. Maximum you can take it to 0.8 kgs per centimeter square. Okay. Now coming back to LSCS. In LSCS, the chances of rupture are less, and because the chances of rupture are less, that is why in next pregnancy, vaginal delivery can be tried, and that is why it is the preferred cesarean section. This is the preferred cesarean section, right? Indication for doing classical cesarean section. Indication is only if LSCS is not possible. If LSCS is not possible, then I am going to do classical cesarean section. Otherwise, we are always going for LSCS. What are the indications for classical cesarean section? When is lower segment not approachable? I cannot approach the lower segment if there are adhesions on lower uterine segment. इतना adhesion है कि bladder is totally stuck onto the lower uterine segment. So now if I give an incision on the lower uterine segment, I might be entering the bladder. Number 2, in case of cancer cervix, which is an absolute indication. Number 3, if it is a very contracted pelvis and you are not able to reach the lower segment, it's a contracted pelvis. Number 4, if it is a placenta previa with blood vessels lying all over the lower segment. All these are relative ones. The absolute one was cancer cervix. Right? If there is a placenta previa with blood vessels all over the lower uterine segment. Blood vessels all over the lower uterine segment. Number 5, please remember, lower segment is formed near term. So if it is an early preterm cesarean section, lower segment bana hi nahi hoga. Right? It's an early preterm cesarean section. Right? And number 6, if it is a perimortem cesarean section. What do you understand by perimortem cesarean section? So if mother, for example, has got cardiac arrest. Now whenever mother has cardiac arrest, within 4 minutes, baby has to be taken out. So if I have to do a cesarean section so quickly and I have to take out the baby, I am not going to search for the lower uterine segment. Immediately I am going to give an incision on the upper uterine segment. So in case of perimortem cesarean section, that is the mother is about to die and I have to take out the fetus within 4 minutes of the maternal death. Right? Clear to all of you? Yes. Okay. Then, what are the contraindications for VBAC or 2 lakh? That is vaginal birth after cesarean section or trial of labor after cesarean section. It's one and the same thing. This is very, very important because in your FMGE exam 2023, there was a question on this topic. right? So what are the contraindications? कभी भी incision अगर upper segment of the uterus में दिया है, and कब दिया है? For example, it's a cesarean, classical cesarean section, या it is a T-shaped cesarean section. T-shaped cesarean section में भी upper uterine segment में incision होगा, right? या it is there is prior history of uterine rupture, या पेशेंट की कोई भी हिस्ट्री है जिसमें कि कोई भी स्कार दिया हुआ है ऑन द यूट्रस, एनी स्कार ऑन द यूट्रस, फॉर एग्जाम्पल मायोमेक्टमी स्कार और हिस्ट्रोटमी स्कार. Why is myomectomy scar or hysterectomy scar a contraindication for VBAC? Please understand, beta. The entire uterus forms the upper uterine segment. Only 0.5 centimeters का एक छोटा सा एरिया होता है, which is called as the isthmus. It is this isthmus which forms the lower segment. पूरा का पूरा uterus is going to form upper uterine segment during pregnancy. So if suppose I have done a myomectomy, right? So non-pregnant patient thi, I did myomectomy, or I did hysterotomy. This is not hysterectomy. I did a surgery on the uterus. So when I am doing a surgery on the uterus, this is the uterus which is going to form upper uterine segment. So ये scar behave करेगा like classical cesarean section का scar. So whenever there is history of uterine rupture, whenever any surgery was done on the uterus, whenever you have done classical cesarean section or a T-shaped cesarean section, it means that next time you cannot do a VBAC, right? Then, if your patient has CPD in present pregnancy, or if your patient is planning a home birth, she has previous history of cesarean section and she's planning a home birth, absolutely not recommended, then that's an absolute contraindication. Relative contraindications, you have to remember if there is macrosomia in present pregnancy, last time I told you, if there is post-term pregnancy, or if there is malpresentation in present pregnancy. These are the three conditions which are relative contraindications. So macrosomia, post-term pregnancy, breech. इनमें से कुछ भी है अगर present pregnancy में and patient has previous history of cesarean section, I will not take her up for vaginal delivery. I will do a repeat cesarean section, right? Now, when this question is going to be asked to you, they are going to say all of the following are contraindications of VBAC except. Please remember, not a contraindication of VBAC. Twins. उस आंसर में twins आएगा because twins is not a contraindication. Polyhydramnios आएगा because polyhydramnios is not a contraindication. Please remember, previous CPD या previous macrosomia या previous breach is also not a contraindication. प्रेजेंट मैक्रोसोमिया होना चाहिए, प्रेजेंट केस में सीपीडी होना चाहिए, प्रेजेंट केस में ब्रीच होना चाहिए, देन इट्स अ कॉन्ट्राइंडिकेशन. क्लियर टू ऑल ऑफ यू? यस? ओके. नाउ देर आर टू स्कोर्स इन OBS which I want to tell you. First tell me, have you understood VBAC? If you've understood VBAC, then I'm going to go to the scores in OBS. Very, very important. Two important scores, that is Bishop score and biophysical score. One score which you are taught in pediatric, APGAR score. Okay. So let us talk about Bishop score. Where is Bishop score used? Bishop score is used for induction of labor. Now, in Bishop score, there are 5 parameters which you have to look at. That is Delhi Police Employed Special Commandos, where D stands for dilatation of the cervix, P stands for position of the cervix, E stands for effacement of the cervix, S stands for station of fetal head, and C stands for consistency of the cervix. Out of these five parameters, 2 parameters को देते हैं score of maximum 2. So Priyanka Chopra, P and C. इनका score is maximum plus 2. बाकी rest 3 parameters का maximum score is plus 3. So the total maximum score which a patient can get is 13. Right? Total score which a patient can get in case of Bishop score is 13. Right? Now in Bishop score, if score is less than 5, that means first ripen the cervix and then do induction of labor. This is not a good score. If score is more than equal to 6, then induction of labor can be done. Right? If score is more than equal to 9, then there are highest chances. There are highest chances of success of induction of labor. Right? Now, what are the drugs which are used for induction of labor? The drugs which are used for induction of labor, number 1, mesoprost. Please remember, अभी तक हम बहुत high doses पढ़ रहे थे mesoprost की for AMTSL and for PPH for abortions. For induction of labor, the dose of mesoprost is 25 micrograms which you have to give per vaginally. Right? Number 2, you can use dinoproston. Dinoproston is the Serviprim gel which we use in our labor rooms. Please remember mesoprost ka side effect. One very important side effect of mesoprost which you have to remember is hyperthermia with chills. So fever with chills. Mesoprost is not contraindicated in asthmatic patients. Right? A relative contraindication for mesoprost is previous cesarean section patients. When it comes to dinoproston gel, that is Serviprim gel, mesoprost is PGE1, dinoproston PGE2. Now, dinoproston, it's contraindicated in asthmatic patients and its side effect is diarrhea. Sorry. That was about carboprost. I'll tell you about carboprost. Carboprost is contraindicated in asthmatic patients and its side effect is diarrhea. Don't write it here. Okay, I'm sorry. I'm very, very sorry here. Okay. So this is about your Bishop score. Another thing which I want you to remember is modified Bishop score. In modified Bishop score, the only thing which is done is that instead of effacement is replaced by length of cervix. Effacement is replaced by length of cervix. So it's Delhi Police left special commandos instead of employed special commandos. Vasant, if you are an FMG student, they will not ask you to calculate Bishop score. If you are a Neet PG student, you will be asked to calculate Bishop score, right? So, length of the cervix is calculated by TVS or it is known by TVS. That is why we don't use modified Bishop score, because modified Bishop score is not a clinical score. You will require ultrasound for doing modified Bishop score, right? Now, then comes your biophysical score or Manning score. Biophysical score or Manning score is the diagnostic test for fetal distress, right? The screening test are NST and modified biophysical score. The screening tests are NST and modified biophysical score. Biophysical score, please remember, it is calculated using ultrasound for 30 minutes. For 30 minutes, the fetus has to be under the ultrasound guidance and you have to calculate the score looking at these 5 parameters on ultrasound. What are the parameters? TB meningitis, always notorious, where T stands for fetal tone, B stands for fetal breathing movement, M stands for gross body movement, A stands for amniotic fluid, and for amniotic fluid you are going to check the single deepest pocket, right? And N stands for NST. To each of these parameters, you have to give a score of +2 or 0. And so maximum score is 10 by 10. To each of the scores, you have to give, to each of the parameters, you have to give a score of +2 or 0. Clear to all of you? Right? Now, what is modified biophysical score? Modified biophysical score में you have to look at only 2 parameters. What are the 2 parameters? Number 1 parameter which you have to look at in modified biophysical score is amniotic fluid index, and number 2 NST, right? So that is what you have to remember about modified biophysical score. Yes? Okay. Then let's talk a little bit about breastfeeding and postpartum period. As far as breech and its maneuvers are concerned, breech and its maneuvers, basically breech and its maneuvers are done in image-based session. They will be asked in the form of images, and that is why in the image-based session, I'll be revising all the breech maneuvers with you, right? Now, this question come and breastfeeding बहुत oftenly पूछी जाती है in your exams. A primigravida gave birth to a male child without any issue for the mother or infant. After how many hours should breastfeeding be started? So tell me, after how many hours should breastfeeding be started? It should be started within 1 hour, right? Okay. So breastfeeding, what is the initial stimulus for breastfeeding? Questions are, it has to be as soon as possible. वहाँ पे within 1 hour दिया था, so our answer is within 1 hour. Initial stimulus for breastfeeding is the decrease in estrogen and progesterone levels. Please remember, this is the initial stimulus. Estrogen and progesterone during pregnancy had a negative effect on prolactin. Now, the moment the placenta is out, estrogen decreases, progesterone decreases. So, the negative effect which estrogen and progesterone had on prolactin is gone, and that is the initial stimulus for breastfeeding. This is your Neet question, right? Hormone responsible for milk production. Hormone responsible for milk production is prolactin, right? Hormone responsible for milk ejection, oxytocin. When are the levels of prolactin highest? Levels of prolactin are highest in the 3rd trimester, followed by breastfeeding. Why in 3rd trimester? Then milk production is not happening because of estrogen and progesterone. Estrogen and progesterone had a negative effect on the action of prolactin, not on the levels of prolactin. What is an absolute contraindication for breastfeeding? Absolute contraindication for breastfeeding is galactosemia or lactose intolerance. or lactose intolerance in the newborn. Lactose intolerance in the newborn baby, right? Now, please remember, following are not a contraindication for breastfeeding. Mastitis is not a contraindication for breastfeeding. HIV in our country is not a contraindication. Hepatitis is not a contraindication. And breast abscess is not a contraindication. These are not a contraindication for breastfeeding. Right? Okay. Then, colostrum. Colostrum has everything more. It's a yellowish colored liquid which comes out initially in the postpartum period. So, this is a light yellow color fluid. Right? And this is rich in immunoglobulins. This is rich in everything. It has everything more in comparison to breast milk, except it has everything more in comparison to breast milk, except. And what is that except? KFC, potassium, fat, carbohydrate, that is your sugar, and calcium. Right? Now tell me, suppose if there is IUD, there is intrauterine death of the fetus. Right? To stop breast milk, production, which drug are you going to advise to the mother? To stop breast milk production, which drug are you going to advise to the mother? Again, a question which was asked in this year in Neet. Which drug? Quickly tell me. Which drug are you going to give? Cabergoline. Cabergoline. You are going to give cabergoline so that the breast milk production stops. Right. Now, there are two terms which you have to remember. One is puerperium, which you already know, and a new term has been introduced recently, that is fourth trimester. You should know both these terms. They can be asked. What is puerperium? Puerperium is the period after birth and till 6 weeks after delivery. Till 6 weeks after, yes, this is for Neet too, beta. This is for Neet also. For till 6 weeks after delivery. And what is fourth trimester? Fourth trimester is the period after childbirth till 12 weeks after delivery. This is a new term which has recently been introduced. Right? Now, all of you know what is the height of the uterus immediately after delivery. Height of the uterus immediately after delivery is just below the umbilicus. Just below the umbilicus, corresponding to 20 weeks of pregnancy. Corresponding to 20 weeks of pregnancy. Right? After that, till 24 hours, height of the uterus remains same. Height of the uterus remains same. And then it decreases by 1 finger breadth. Then it decreases by 1 finger breadth per day. Right? So, in Neet, there was a question that on day 2, what will be the height of the uterus? On day 2, the height of the uterus will be 1 finger breadth below the umbilicus. Right? After that, it decreases by 1 finger breadth per day. Please remember, if they ask you that when will, very, very important question, when will the height of uterus be midway between pubic symphysis and umbilicus? When will the height of the uterus be midway between pubic symphysis and umbilicus? When will it be midway? Anyone? At the end of 1 week after delivery. 1 week after delivery. Right? Next question. When will uterus become a pelvic organ? In days, it is 10 to 12 days. In weeks, it is 2 weeks. Days पूछा जाएगा तो 10 to 12 days. Weeks पूछे जाएंगे तो 2 weeks. When is the weight of the uterus equal to the weight of non-pregnant uterus? 6 weeks. Right? Next important question. Contraception in a breastfeeding female. When should you start contraception in a breastfeeding female? By 3 months. And when should you start contraception in a non-breastfeeding female? By 3 weeks. Right? By 3 weeks. A few more important points which I want all of you to know. Have you copied these points till here? A few important one-liners which I want you to know. What is the most common cause of uterine subinvolution? Please remember, the most common cause of uterine subinvolution is postpartum thrombophlebitis. Right? Then if they ask you, after pains are due to, what is after pain? After pain is the pain which happens when a baby is suckling the breast. At that time, mother can have pain in abdomen. That is what is called as after pain. And this is because of oxytocin. Why? जब mother breastfeed कराती है, at that time oxytocin is released, and oxytocin leads to uterine contractions. So after pain is happening because of oxytocin. If they ask you that a female is having postpartum shivering, that is because of 2 reasons, beta. Number 1, it could be कि आपने mother को mesoprost दिया है, right? Mesoprost की वजह से भी shivering हो सकती है. And number 2, it can happen due to blood loss, right? It can be due to mesoprost also, right? Now, when does HCG return to normal after delivery? HCG returns to normal after delivery in 2 weeks. When does cardiac output return to normal after delivery? 10 days. What is the most common postpartum neuropathy? Most common postpartum neuropathy is lateral cutaneous nerve of thigh. Order of lochia. Order of lochia, lochia rubra, lochia serosa, lochia alba. That is the order of lochia. Till when can lochia be discharged? Lochia can be discharged till 4 to 6 weeks. I want all of you to take a screenshot of this slide. Take a screenshot of this slide. This is very, very important. Right? Then, as I told you, that contraception should be started in a breastfeeding mother by 3 months, in a non-breastfeeding mother by 3 weeks. When to start breastfeeding? As soon as possible, within 1 hour. Right? What is the contraception of choice? Contraception of choice is progesterone only pills. That is the contraception of choice in the postpartum period. Right? And if POPs is not given, then IUCDs. Contraindications for breastfeeding, I have told you. Absolute contraindication is galactosemia. Other contraindications are active pulmonary tuberculosis, active chickenpox infection, active herpes infection. Please remember, I told you HIV, mastitis, breast abscess and hepatitis, they are not a contraindication. Right? So, that is all what I wanted to tell you in OBS. OBS mein you have to remember this much only. I will be taking up your gynae revision after this. This is an important quote, my message to all of you, that some people want it to happen, some wish it would happen, and others make it happen. And I know all my bachas, you are going to make it happen with your hard work and with your dedication. All the best to all of you who have to give their exam on 23rd. The Neet PG bachas and FMG bachas, you still have time. Please, at this point of time, focus only and only on high yielding topics and on PYQs. Nothing else is required. Nothing new needs to be done at this point of time. It is 12 o'clock. I am going to see you at 1 o'clock with the gynae revision. right? So see you at 1 o'clock, and yes, please remember this is your lunch break as well as your breakfast, whatever you want to have at this point of time, because once I begin with gynae, I'm not going to give you any break. From 1 o'clock to 5 o'clock or 4:30, whatever time it takes, it is going to be gynae revision, right?